Okay, hopefully we're all back now. There's so many of us, I can't count. And you move around on the screen. So, okay, we need to move on with the next part of the agenda. But for those that are interested, West Indies won the toss and England have been asked to bat. Maybe it was just for Martin and Beach. But it wasn't me that picked the time of the break. It was Jill. Right. Okay. If we move forward now to item number 14, which is the joint forward plan. Sue.
Thank you. I did wonder what you were talking about. Don't really understand cricket, but Carol, I'm sure you're pleased too. Yeah, I wasn't going to do too much around this. We've seen this document previously. Obviously, it's an update to the Joint Forward Plan, which is a system document very much outlining the NHS contribution to the overall integrated care strategy. This is an update that's going around all of the boards at the moment. So there's a sea of appendices, which in tab 31 of diligence, so they're there for reference. The updates are very much around the changes that we've seen in our systems. So Worcester Acute going into the foundation group. We've obviously done the demand and capacity modelling, sitting around the point prevalence audit. So that's been updated and included. Some further work really around the 24-25 performance trajectories, because the planning guidance came out later. They've then obviously rolled into this document. So as I say, it's an update. Happy to take any comments. And as I say, I mean, I think we've looked at this on a number of occasions, and it's an important document for us in terms of our contribution into that integrated care space.
Thank you, Sue. And I suppose, as when it was published, I found my picture was on it, then I need to state that I endorse it. The joint plan as said on the front page, along with my chair and primary care colleagues. Does anybody have any questions around this? As Sue indicated, we've been through this a number of times. It's an evolving thing, as the ICB is. I feel sure that Martin will keep on top of the health inequalities element of the document, because the document continues to put this at the heart of what we do. Yet I think by everybody's admission, we're not sure that we actually push towards this hard enough. But Martin's our representative on that group, will do so. If there's no one else who wishes to speak, because we've seen this all before, can I ask board to endorse this document as we're being asked to do? Okay, in that case, thank you very much. Consider our support from this trust to our ICB, and Martin as our, Robert as our partner member, and myself as an attendee will continue to support as much as we can. Moving now to Matthew and the operational update. I know he's touched upon one or two things, but Matthew.
Thank you very much. I assume obviously everybody's aware. I'll just draw your attention to the following points. The latest in an extended period industrial action at the end of June, we were able to deliver services well across the system throughout that period. We meet regularly in the lead up to industrial action, and we plan together, and we were able to deliver all services across the system with very minimal disruption. Around 46% of our junior doctors did take industrial action in this organisation. But we were actually able to maintain all of our planned activity. There is a cumulative effect, though, of industrial action, in that some of the arrangements for clinical cover are not sustainable in the long run. So there's only a certain amount of times you can keep asking people to cover down and then for be willing to do that. The BMA is also balloting GPs as well. The ballot runs through to the end of July. It's in respect to their primary care roles to do with the GP contracts, and not GPs working within organisations, but GPs working in primary care practice. The recent change in government, trade unions have indicated, may lead to suspension of further planned action dependent on the outcomes of engagement talks. Our 136 suite has now reopened at the Elgar unit, and has had remediated the environmental issues identified by the CQC in their inspection. So it's effectively a refurbished unit now, with alternative means of escape, good furniture, and importantly for staff as well, the ability to exit the unit from an alternative means through the office as well. Our acute bed position remains challenged. Update to the paper, we've got currently 5 inappropriate out of area placements, and the national target is of course 0. There are only 5 trusts in the country that have got to 0. The root cause for us remains the high number of patients with complex discharge needs. We've had an unusual number of patients since January who've entered hospital, and on entering hospital we've uncovered a very difficult social situation, which means that onward care needs to be different than inbound care. And there's no evidence of increased admission levels or acuity. We've gone back quite thoroughly over our admission numbers, and we're getting some further breakdown on those as well. But we roll out at around 450 admissions a year. We're actually predicting slightly less than that. So no more admissions. Patients are very similar to the ones that we've always seen in acute care as well. Staff from all disciplines are well engaged in a comprehensive improvement plan, though, that was presented at July's Finance Performance Committee. And we continue to monitor that through integrated governance. In our paediatric services, we've commenced with a balanced system framework review, which is ourselves working with all the partners across the system to develop the universal and targeted offer, so the offer that's available to all children, the offer that is available with our support. And that allows us as specialist health providers to work more quickly with children with the most challenging needs. It's a 2-year program at the very least. So it took us 2 years to work through speech and language therapy. But the result of the end of our speech and language therapy balance program is that we're leading the region with access times for children. So there's very little effective wait for children accessing speech and language therapy. And our hope would be we work through pediatric OT and physiotherapy to achieve the same results. We've received permanent funding for 2 lead therapists as well to enable that program to proceed with the right kind of clinical leadership as well. As well, in Children and Young People Services, we welcome the ICB's commitment to increased investment in children's mental health services, and they've begun now the procurement process, which will lead to new services across the 2 counties from April 2025. Sue mentioned earlier the 7-day services priorities audit. Just for a bit of detail, this is part of the national NHSE contract with acute hospitals. So the aim of it is to ensure that everybody coming to hospital on whatever day of the week, being treated whatever day of the week, has the same access to diagnostics, clinical oversight. So there's consultants overseeing care 7 days a week, and they can be discharged as easily and also report their patient experience. So all acute hospitals have to select a number of standards from the standards pack and report on those in their annual quality report. We're directly involved in 2 of the standards, so Standard 7 and Standard 9, which are mental health 24-hour, 7-day-a-week liaison services, and discharge coordination being available 7 days a week. And we're slightly ahead, I suppose, as a system around the discharge coordination, because you're well aware that we led the redesign of this in 2020, which led to some of the intermediate care teams that we've got in place now. And further on, I guess I'd draw people's attention to the collaborative program of work with the urgent care system in the Worcestershire place. So ourselves, the ICB, the Acute Trust are working closely together. One is around better use of resources, so pooling the expertise and the resource that we've got, using that more effectively around alternatives to admission, so keeping people out of hospital, moving people out of hospital more quickly, and reducing delays in discharge. So when first of all, ensuring that people's correct pathway of care is identified earlier on, and that if they need that pathway of care, actually we're making sure the processes that enable that to happen are operating as smoothly as possible. And that work is overseen by the Place Integrated Care Delivery Group. Thank you.
Thanks, Matthew. I have a question and a point. Does anybody else have any questions at all? Sue?
Yes, I mean, it may be too early to answer these questions about the SEND report, but in terms of the balanced approach, where we're discussing physio, OT and community paediatrics, it says in the report, the system is dependent on buy-in from the local area partnership. At present, key stakeholders are not part of the planning for this system. And I wondered if we knew which stakeholders they were referring to, and or whether that is maybe out of date because things have moved on since the report was actually, developed.
Well, there's kind of two levels to that question. So in order for a balanced system to work its way through properly, all schools or representatives of schools need to be present, because a lot of what needs to be delivered for children with different needs is delivered through schools and at schools by people who aren't necessarily specialists in that area. And not all school representatives have previously been at the table. And there's some other parties that could have been involved that I guess weren't as involved previously as they could have been. I think that's moved on. So we've got a group that is meeting very regularly to oversee the performance accelerated plan. I'm going to get my names of some of those mixed up because I keep calling it something different. And we've that's being overseen by the SEND improvement board as well. So we've now got the people at the table. We've now got a plan that's got the right people engaged in it. At the time of the writing of the report, that wasn't the case. Obviously, our successful delivery of this does rely though on all the partners agreeing to continue to come together, to invest where investment's required, and to remain at the table and committed to delivering services differently.
I mean, you mentioned schools, but what about early years in those areas?
Yep. Absolutely, this is for children from birth upwards. The reason I mentioned schools is because it's the most variable element in delivery of any children's service. Every school pretty much operates independently with its own set of policies and approaches to children.
Yeah, so when we did the speech and language therapy development, schools were involved at that stage, were they?
Yes, they absolutely were, and it's been successful because we've put together packages for schools that enable them to deliver some of the non-specialist components of speech and language therapy through teachers and teaching assistants, especially where children have identified needs through SEND and have an educational health and care plan.
I mean, I suppose I can see how schools can develop oracy skills, but I can't see how schools can help with physio and occupational therapy.
Yeah, well, absolutely, they can. I realise we're getting into quite a lot of detail here, but absolutely they can help. So if a child has an ongoing physiotherapy program, there are adaptations that you can ensure that are in place in schools. There are approaches that all schools can use for children with different abilities, and there are specific skills that can be taught to teaching assistants and teachers to meet the needs of children with different needs. So there definitely are. There are some things at universal level that are skills based or environmentally based that can be adapted so that non-specialists can deliver them effectively for the benefit of the child.
Okay, and we're sure that line is referring to schools and not not any other organisations or individuals?
Schools are one of the elemental pieces that weren't perhaps not sufficiently engaged in that previously.
Matthew, can I make a suggestion? Sue, you have undoubted expertise and background in this area, obviously, and I think that's right that you bring it to bear to ensure that we as an organisation are doing all that we can. Can I ask you, Matthew, to keep Sue informed of developments in these areas? Two reasons. One, Sue's got an interest, but she also has an expertise as well that may be useful to bring to bear. And I think that would be a useful way of ensuring that we grab hold of Sue's expertise and use it wisely. Is that okay, Sue?
Yeah, no, absolutely. And I know we're going to talk about this more this afternoon, and it's just very early days, but I just want us to be talking about it because it is out there, and there are some quite critical comments in it.
Yep. Okay, thank you. Janet.
Yeah, thank you, Mark. This is a question about the acute adult mental health inpatient admissions, and just noting on the table on page 102 of Diligent that actually admissions have dropped year by year, and I just wondered whether you can assure us that actually that people who aren't being admitted are actually receiving appropriate care, and that we haven't got a gap somewhere.
Yep. So I think that there's a good reason why they've dropped. So the first thing to say is there's an artificial peak in this. So in 21, 22 and 22, 23, no, sorry, 2021 and 21, 22, we and everybody in England had a significant post-COVID peak. So what had happened in COVID is a lot of people with serious mental health problems either had services delivered to them in a different way, which resulted in deterioration of their health and subsequent admission to hospital. I remember deterioration can take place over several months, so there's a bit of a lag in this. But also a lot of people had lost contact with things that were keeping them well and keeping them well integrated in society. And so that's we saw this, a lot of people saw this. We now feel we're back to a baseline. Now, the other thing that's happened is that the Mental Health Investment Standard has continued to invest in crisis resolution home treatment teams, things like mental health liaison teams that may interface with people, and things like crisis helplines as well. So there are more ways that people can get different levels of support as they need them. And as we've developed our neighbourhood mental health teams as well, we've now got more people, and this is something that we have to report back to NHS England, who are able to access a mental health support service in the community. So we've got much bigger community mental health services than we previously did. So we're able to offer a wider range of services. So rather than thinking there might be people that are ill and slipping through the gap, I guess our confidence is more that people who've got high levels of needs have got more provided to them.
Thank you, Matthew. A couple of things from myself. Inappropriate out-of-area placements. Yesterday, Robert at the ICB took the opportunity to remind ICB members that we're actually quite high performing in this area. And I think you indicate, your paper says 8, and I think we're about 5 now was the update that you gave. Just to remind board, and indeed if anybody's watching, that there are areas of the country where trusts have the numbers of out-of-area placements are in the hundreds. So we're at 5 at this moment in time. But I also note your report, Matthew, says those out-of-area replacements can be in such places as South Birmingham and indeed Worcestershire, which doesn't sound out of place, out of area, but it's obviously not within our trust care. So even though they might be out of area, it might not be as far away as people think. Is that correct?
That is right. We've more recently we've been working with a couple of provider groups as preferential providers of services. So we're not contracted with them, but we've developed a relationship with them around where we need additional capacity admitting patients locally. The reason they're counted as out of area is that for a patient to be in area, they have to be part of the commissioned service of that area. So the paradox is that you could actually have a hospital that was far further away, but it could be recognised as an in-area hospital, but it's because it's part of the contracted delivery of mental health services in that area. So I'll give you an example. So patients in Lincolnshire, if they're going into an intensive care unit, will go into an intensive care unit in Cambridge. And if you know that part of the world, that's a long way away. It's over an hour's drive, but it's in area because it's contracted. So it's just one of the peculiarities of how that definition works.
Okay, thank you, Matthew, because where my thoughts were about carers' loved ones, having to drive out of area, and that's not always the case, as you've just explained. Okay, thank you for that update. If there's nothing else there, we can note that report and move to update on Freedom to Speak Up, and our Freedom to Speak Up Guardian lead can't be with us today. She's on prearranged annual leave, so our non-executive Freedom to Speak Up lead will be delivering this report as she was at the workforce meeting, indeed chaired it, and heard the report delivered by Natasha. Vina.
Thank you. So I think the first point I wanted to highlight is that the board paper is a very condensed version of the much more detailed paper we discussed at Workforce Committee, which included helpful graphs and charts demonstrating, that increased activity around Freedom to Speak Up in the year from 2023 to 31st of March 24. And in fact, a lot has happened even since the 31st of March, including the Manager's Guide being published. And we've also had the recent Pulse survey results from May, June, which show an increase in the number of people reporting a positive experience when speaking up. And interestingly, since coming into post, Natasha has dealt with around, Natasha, our Freedom to Speak Up Guardian, she's dealt with around 170 concerns, 170. And by the end of August, we're going to have 35 Freedom to Speak Up champions trained up. So you can see that the traction that's been gained over that time. There's been a 44% increase in the number of concerns that have been raised in the past year, which I think really clearly reflects the proactive work that's been undertaken to encourage people to engage. That higher reporting rate could be interpreted in two ways, obviously. It could be an indication of an increase in staff concerns, or it's a result of the positive speak up culture we have, where staff feel confident to use the process. We think and we hope it's more of the case of the latter, based on a number of factors, really. Firstly, the Freedom to Speak Up Guardian resource has been increased. That was originally 0.2 of a whole-time post. It's now a full-time post. It's now easier to report concerns. There's a digital platform. There's been a significant increase in the Freedom to Speak Up champions who are out there raising awareness. And significantly, as a trust, we have lower than average rate of concerns that are raised anonymously. So within our trust, only 2% of those concerns are raised anonymously. Nationally, that figure is around 9%. So there's quite a difference there. We also have a higher than average positive feedback regarding the Freedom to Speak Up process compared to national figures. So I would suggest that the increase in the number of people raising concerns isn't necessarily a sinister thing. However, when surveyed, our staff have reported high levels of feelings of futility, that feeling that speaking up may not actually make a huge difference. It's also taking too long for the relevant leaders to even have the initial conversations with that person, let alone taking active steps to address the problem. It goes without saying that once somebody does speak up, once somebody does raise a concern, it becomes an incredibly stressful time for them, waiting to see how that issue is going to be addressed. And when I spoke to Natasha about this, she was really clear that our biggest risk in this area is in relation to our leadership capacity to respond appropriately. It just comes down to capacity, I think. And managers have told our Freedom to Speak Up Guardian that, you know, they know that dealing with staffing concerns is a priority, but patient needs are more of a priority. So that's what they're going to deal with. But, you know, we can't make our patients a priority if our staff don't feel safe working with us. So it is one of those wicked problems, I think. We also know that when staff have a poor experience, once they have spoken up, they're going to share that with their work colleagues, which then undermines all the work that Natasha and her team have done. You know, it corrodes the confidence that's necessary to make this process work. I think I've covered most of the points in the report. As I mentioned, we do now have a manager's guide to help managers better understand how they should respond. I don't think the communication cascade has been as effective as Natasha would have liked, despite the fact that that guide has been shared widely. It's now available on our intranet. You know, few managers have seemed to be taken notice of it. So Natasha's now actively involved and attending IG meetings, you know, to remind leaders about that guide and provide kind of bespoke feedback to those leadership structures. She's also going to be delivering specific training to managers as part of the leadership development programme that starts in September. So for the coming year, we have a 12-month action plan, and I understand that Natasha's going to be providing a progress report on that at Workforce in September, which should also be covered at board in September, I think. I think ultimately Natasha wants me to make two specific points. Firstly, the fact that we can't look after our staff. If we can't look after our staff, we can't look after our patients effectively. So we've got to address that capacity issue. The second point, she was very insistent that I make this point, she does want to thank board and indeed all leaders who have been so supportive of this work. She knows that the goodwill is there. She's absolutely clear about that, and she wanted me to make that clear. But ultimately, the success or otherwise of this is going to be dependent on creating that capacity to address these concerns when staff do speak up. I hope that covers everything, but I'm very happy to take questions.
Thank you, Vina. Before I do open it up to questions, Elaine, I'm aware we're looking after your voice and you're looking after your voice, I know. Is there anything you wish to add before I open, as the executive lead for this, anything you wish to add before I open up to the floor?
No, only to say that Natasha's been very proactive over the last year. I've worked really closely with her to get some the momentum that we've managed to achieve, but we do have the challenge around capacity for managers to do this, and some of that is a mindset piece. Is my view. It has to have equal weighting with the care we give to our patients, includes the care we give to our staff as well. So yeah, that would be my only addition.
Thanks, Elaine. I've got two people indicating they wish to make a point or ask a question. I've got Beej and then Sue, please. Beej.
Thank you. Thanks, Vina, for that. I totally agree that staff morale, good staff morale, staff mood, confidence in at work, happiness in their professional lives and probably personal lives is absolutely linked to delivering great patient outcomes. So we have to make sure we look after our staff. What is interesting about freedom to speak up, and I personally think it's a great idea, is it's very difficult to work out what success looks like, because is more workload coming in for freedom to speak up a success, or is it that we are therefore failing in other more open, more transparent methods that staff members are therefore not choosing to take in order to express whatever they're thinking? So it's, you know, I'm sort of both pleased that Natasha is busy and also worried that there's a there's a growing amount of people who are seeking to use this as a method. Whilst I totally agree that methods need to be available, whistleblowing and various other things for staff, especially in a patient environment. Specifically, though, and you can comment on that, and I'm not sure what I even think success looks like, and I'd welcome your thoughts. But specifically, also having spoken to a few people at various events, the SLT was the most recent one. It was clear that there is a feeling that there isn't anonymity here, even if it's required. So I wonder whether we can be doing more to convince staff that actually, should they wish, this is an anonymous process, and guarantee, or at least give them confidence that that is the case.
I don't know who's going to take that. I know, Elaine, I'm conscious of your voice, so I don't know if you wish to take that, or Veena. I don't want to take away from the executive's roles.
I'll attempt to answer that, Paige. I think the issue of anonymity is a slow burn. People have to trust that when they say something, something happens, and they don't feel that they're going to be called out or identified in a process. And I think that that takes time. It is also about the actions that our managers take when an issue is raised with them, and that there is a degree of speed around the response. This is a cultural change piece. We know people have real apprehension even around our NSS approach, and that's not really anonymous. We have to change that, but we can only change that by them seeing, I've raised it, it's being dealt with, and I've not felt exposed. And I think it's a bit by the, you said, we did, or I've said, and this has happened, and it's made it better for my experience. So I think it's over two-handed. People have to see that and feel that it feels safer to do it, and that it's okay to raise issues. And that doesn't happen overnight. If historically what they feel is, I raise an issue and something awful or negative happens to me as a result, and my experience is made worse.
Thanks, Elaine. Veena, do you want to comment on that before I go to other questions?
Thank you. I mean, to answer your first point, Bij, I would be really worried if we had lower numbers of people speaking up. That would concern me more. However, you know, I think, Elaine, you've absolutely made the point that it comes down to people trusting the process. And whilst I've stressed the challenge we have around capacity, you know, because managers don't feel they have the time to open that can of worms. It's tempting sometimes to just leave it in the in tray. Some of this also comes down to capability, and we do know that occasionally managers have kind of thought, right, well, I'll use my time efficiently. So as well as talking about the employee's concern, I'm also going to be use this meeting to talk about my concerns about their work. And it's, that can send out completely the wrong message. And that's not to suggest that we're dealing with a terrible manager. These managers haven't had the training in very many years, so it's our responsibility to ensure that training and that support is made available. But it requires an investment.
Thanks, Veena. Well, Sue, Martin, and then we'll finish with Scott. Sue.
I think Veena's largely answered my question. So it was really, how we're defining capacity. So you've talked about the sort of time to open a can of worms, capability. Are we talking also about prioritization of staff needs over patient needs? And then in terms of what we do about it, presumably the discussions with managers who might need to deal with whistleblowing is to say that despite these aspects, this is important. So we have to address the reasons why you think you haven't got the capacity to deal with something. Would that be a fair summary? Yeah, thank you.
would you like me to respond to that?
If there is a response,
yeah,
yes.
just one point, if that's okay. All of the above, Sue, but also, you know, where Natasha's role becomes really important is that when employees have raised concerns, and very often they will have raised concerns to a number of managers at different levels before they go to her. And what Natasha has the ability to do is go to assistant directors, go to SDU leads and highlight to them, look, this is a really significant problem. You know, I understand managers are under a lot of pressure, but you need to be aware, and you as the SDU lead need to decide whether this is priority or not. And I know that when she has gone to SDU leads, that intervention has made that difference. It's allowed people to just, you know, look at it with a finer focus.
Thanks, Veena. Martin.
Yeah, thank you. We talked a lot about putting emphasis on psychological safety of those who are raising concerns. Absolutely right. But because this is fundamentally about a culture change, to what extent have we been doing work on psychological safety with those leaders and managers who we're asking to promote the scheme, that when things are raised, we're not a finger-pointing organisation, we're a genuine learning organisation, and this isn't about blame, this is about a learning culture in the same way that it is in the airline industry or whatever. And is that part of our culture transformation improvement plan being focused on as much as it is around providing psychological safety for those asking questions?
Can I hold Elaine and Veena there, because Scott was going to ask a question, and I think this falls right into Scott's remit of the improvement plan. So if you can pick up, Scott, if you can pick up Martin's point, please, and then whatever else you're going to mention, please.
To be honest, it's all in and about that space. So the couple of things I just wanted to draw out was the point about having more people coming forward. That's something we're seeing across a number of channels. So also with Pulse, also the rumour mill. So I think for me it is positive that people are feeling able to come forward and thinking something would happen. The other point actually really aligns strongly with the point you've made there, Martin. We are just designing the next stage of the culture change programme at the moment, and psychological safety is a hugely important component of that, as it is an enabler to a number of the changes we need to make. But also picking up on the point around the training programme. So the managers training programme is relaunching with the first sessions, module 1, starting in September. Throughout this, we'll be working with managers to understand, well, you know, what does a good response look like? What are the appropriate steps to make? And actually, as an organisation who's wanting to be a learning organisation, how is it we receive this information? How is it we approach it? I'm not saying it's going to be a quick journey, but yes, you're absolutely right. These are the key components of how we move of how we move from A to B.
Thank you, Scott. And just to complete, with regard to the increase in the numbers, if I go back to my previous professional role there and health and safety, there's a direct correlation between the amount of health and safety reports, normally near misses, and the amount of resource and awareness of health and safety. And I think there's a direct crossover to freedom to speak up. The more resource, the more awareness, the more reports we get. And I personally can see it as a success, although we do need to be quizzical in the way that Beej was with regard to why they're coming to freedom to speak up, and perhaps not management. Okay, thank you, Veena. Thank you, Elaine. Can we note that report? Thank you very much, and move to, almost like seamlessly, Scott, and just a quick update on the improvement plan. Scott.
Yeah, Chair, I was just going to pick up headlines and then I'll draw Scott in terms of where we are with the improvement programme.
Apologies.
And really, it was just to start out. You recall last board we had the first of our updates, but it was slightly ad hoc in terms of what we brought. and we committed to make that a standing agenda item, and we'd bring back a more formal report. So that's what we're doing here. The other bits I did want to draw out before we get into the detail, and obviously you've got a summary in the report of activities we've been undertaking, is we are also just part way through reviewing the governance that we have around this and the reporting arrangements, and also board's aware that we've committed to putting a role in for the next 3 years to support the improvement programme, because this is about a long haul cultural improvement process. We've obviously had early discussions about the specific CQC must do actions, which we've very much picked up through Natalie's oversight through Q&S and so forth. So by the time we get to September board, again, I'd expect this to have slightly changed and us to have clarity on how we're going to do that in terms of governance. Just in terms of the report, I was just going to draw out a few key points from my perspective, and then we'll pick up any questions and absolutely draw Scott in. So what you can see from the report is starting to see some of the ways we're going to be tracking things through. So I'll just refer you to the graphics we've got around the culture score and how we're using the Pulse survey. Really pleasing engagement with Pulse in terms of the numbers taking part, which gets us to a much more representative sample across the organisation. Lots of discussion so far today about the need to not just hear things, but to be seen to be taking action and making some positive changes. So the you said we did is a key part of it, and how we do that. There's a reminder in the report about how much engagement we've done with staff and some of the additional engagement that we've done, particularly with facilities, estate staff and corporate teams to supplement the kind of the original broad-reaching part. Scott did just touch on briefly the fact we're just going through the process of designing the phase 2 for the culture part. That is pretty much coming together now over the next couple of weeks in terms of what we're doing, but key aspects in terms of psychological safety, in terms of how we enable our staff to feel they have a voice and that we will listen to that. We're probably around about a month or so off where we need to be in terms of the inclusivity side. So there's a significant piece of work that we need to do, which I'd hope to be able to report back a little bit more in terms of where we are around being anti-racist organisation and more broadly on inclusivity. We've got some work set up to do, but board will also be cognizant of the fact we've got an approved strategy from March around EDIE and a number of actions that we are working on to deliver. And then the final part I just wanted to draw to everyone's attention really was how we are drawing that through in terms of some of the key risks and prioritisation. And I think we've had quite a lot of discussion just in the last piece, which is about being clear about what matters. We're going to have some focus, and we're going to have to be quite cognizant of the need to balance that, because it is going to be about things that are going to be the most impactful and making sure we're able to gain assurance that they are doing what we need them to do and that they are they're on track in terms of delivery. So I'm going to pause there, Mark, and invite any questions.
Martin, you preempted me. Martin.
Yeah, thank you very much. I absolutely 100% very keen on the improvement plan, and we've got the right areas. I just want to have a view on where we're measuring the success of the progress of the improvement plan versus how we're measuring the success of the CQC must do plan, which we put at assurance level 2. We're putting this one at a level 4, and the emphasis on the CQC plan was on sustainability. And I think here we're actually looking at progress of the plan rather than ongoing sustainability of what is a very, very difficult culture change and measuring the sustainability of that over a serious period. Are we measuring apples with apples when we're looking at the same assurance criteria? Because my sense is that the CQC must-do plan is progressing along the same trajectory as the improvement plan. But thoughts?
So we did have some discussion about this in the committee round. I guess the point of clarity is we are trying to work through some of those measures of success. One of the things I want to do with the team and with colleagues here is both carve out some measures of success for the long haul, so that cultural transformation piece, which is going to take us, a number of years, albeit with clear milestones and waypoints, as opposed to some of the things that we've quite clearly committed to do over the next 3, 6, 9 months. So if you look at the overall improvement plan, Martin, we've got 6 clear work streams. Actually, we've got some of those that are very clear deliverables for this year, albeit they will, in terms of impact, increase over time beyond that. But there are some things that are the here and now, and there are some things that are about our journey over the three years. I think where we got to when we looked at this was, if you think about this, really, we've had a diagnostic process that stretches back now over 12 months or 12 months thereabouts. We've spent quite a lot of time reflecting on that and then drawing together a delivery programme. And if you looked at kind of the pure scoring around our 7 levels of assurance, have you diagnosed the problem? Have you got a plan? Are you delivering it? No, you haven't seen all the outcomes being delivered in full. We are on that basis around about 4. I think we had that discussion. I do think we need to be clear about that. Personally, my view is that we will look to have a plan that we own. We agree at the start of a year. We'll need to monitor and assure ourselves against that in year. And that would, I hope, link to some more medium-term methods of assessing performance and delivery for that overall cultural change that we want to achieve over a 2 to 3 year period. So I think there's a little bit more work to do on that, Martin, but that's what this is reflecting.
Okay, if there's nothing else, make sure we keep ourselves topped up on our improvement journey on feels like a daily, certainly weekly basis, but it's useful to bring to board with a formal paper every time then. Okay, thank you very much indeed. If we can note that report, and we'll now move to the part of the agenda which is the more sort of routine reporting of our committee work, and we'll start with quality and safety. Janet, are you kicking off? Or is it?
Yeah, thank you.
Natalie, I'm not sure.
I'll do the report from the committee, and then I think Natalie will do the quality and safety report. Just to say, to start with, that I'm sure you'll have noticed that actually we put this report into a different format this month, and that's, well, obviously it's deliberate, but what we've done is we've picked up the format that's being used to the committee for the integrated governance reports that have come through to quality and safety, and they take this format, and actually we found it really useful in enabling us to focus on the areas where we think there may be issues or where we actually need to spend our time, but it does mean that we're getting a rounded picture. So we've used this format twice for Q&S with the reports from integrated governance, and thought it would be useful to just try it out for the report to board. So I'd be interested really in what people think. We've managed to get it into 4 pages. I think we could probably reduce that if we actually had smaller headings, get it in well under the line. We've divided it up into the areas for alert, which are ones which actually tend to have been where we've got areas where we need to have risk summits. And you'll see that there are a number of areas there, largely around I think probably pressures in those teams due to workload and staffing. And so risk summits will be held, and we will get reports back to the following committee to assure us that actually action is being taken. You'll also notice in this area we have put the discussion that we had around Hillcrest, which obviously we've already had today. In the advise section, we've pulled out areas where actually they're probably less well, I don't know what the word is, not less important, but where we can maybe have more assurance, but still need to keep an eye on. And so again, that tends to have been feedback from previous risk summits. You'll see around joint which rules and obviously staffing issues, but also the discussion that we've had here about the CQC must-dos. We've divided up the assurance levels, and this is purely arbitrary, into those which have actually assured sort of 5 and below, that actually we feel, again, we need to really be cited on and be assured that those are improving, not getting worse, which is indeed the case, but ones which we do need to be aware of. The next section is around assurance, and this is really where actually we've had assurance and we've put assurance levels of sort of 5 and above into this area. And then finally, the bit I did want to pick out is the achievements, because I think this is important, and very often when we report from committees, we focus on the areas where we have concerns and we've been we want deep dives and we're worried about, and maybe we miss the achievements. And I think we've got 2 fairly significant achievements here. And we've had one of our learning disability nurses shortlisted for Nurse of the Year, which is pretty amazing, particularly when she's looking at work around relationships and sex education, given the focus that we've been taking on sexual safety within our organisation. And then the second one is the annual community mental health survey, which is a survey of our patients themselves. And last year, I think I'm right in saying we had some concerns about some of the responses. But this year, as you will see, we're actually rated best in the country in some areas, which is again something which I think we should celebrate, particularly when we're doing a lot of work in that area, and our staff are really focusing on it. So I just wanted to give that due weight in the report to the board.
Thank you, Janet. Anybody got any questions of Janet there? I think from the comments there was a general support of the format and also the fact that we can identify successes. And indeed on that final one you mentioned there, Janet, of course, that's what Robert and I wrote to the team leaders with regard to that survey. Martin.
Yeah, thank you, Janet. Love the format. It's very clear. I just want to pick up on the alert there at the top in terms of Worcester City Inpatient Unit, which has been a sort of recurring theme of this is a care environment which isn't fit for purpose, but we have to make do. Should we be, or can we look at, or do we have any plans to look at alternative provision of that unit over time, that we don't end up in the same situation we've ended up with Hillcrest of saying this is an inappropriate care environment, there's too risky, etc. Or are we now happy that we can manage in that care environment with the appropriate mitigations that take place? But it has been a recurring theme over certainly 7 years.
Yeah, indeed. I think that's probably one for either Natalie or Matthew to pick up.
I'll happily pick that up if that helps.
Cute.
So that's part of the risk summits. One of the actions is to review. So for those of you who aren't aware, it's the IAR pathway. Pathway 3 has most of the beds within that unit, and part of the risk summit is a review of that pathway and if it's still the right provision for that service. So if the risk summit will focus on kind of immediate, medium and long-term actions to reduce the risks that they're currently experiencing.
Thank you.
Thanks all. If we can note that report and move to Natalie, then are you going to take the quality and safety report, Natalie?
Absolutely, and hopefully again we've shortened it by half. So hopefully that's more digestible for people. And again, just a bit of a reminder. So patient safety and quality is divided into 3 pillars, which is patient safety, clinical effectiveness and patient experience. So I'll take the report as read, but just to pull out the most salient points. Patient safety, we continue with our rollout and delivery of PSURF, which is the new framework, which is going really well. We have 6 subgroups based on national and local identified themes to focus on, which are, they each now have a working group with a clear development plan underneath them. And the initial feedback from staff who have been involved in patient safety responses and other methodologies to investigate incidents have been really positive about how it feels very different, and they feel much more listened to and like it's much more of a learning environment. So that's really positive. Clinical effectiveness focus really on mortality oversight group, which is bringing together end of life strategy, a suicide prevention strategy, introducing and including the learning from LEADER, which is the learning disability death reviews, as well as our new bespoke approach to risk assessment, which was changed in line with national guidance. And we've launched the training, and the full launch of the new protocol and policy is in October, so making really good progress. And then finally, for patient experience, really pleased to confirm the complaints response continues to improve, so the response times continue to improve. We continue with the rollout of care opinions, and you've got a sample there of a care opinions dashboard, and that rollout is going really well across the organisation. And we have a new health inequalities group, which is chaired by Sue Harris. So that's a new group we've commenced, which will report through QNS, and that will now be the home for PCREF as we work through the PCREF priorities of this year, as well as multiple other factors. I'm happy to take questions.
Thank you, Natalie. Any questions at all? Compliment to the format, Natalie. I certainly like the little addition of the arrows now in the executive summary to tell us whether the assurance level's gone up, down, or stayed the same. And just, I think the point that I took from your care opinion is that the vast majority of the comments that are made are actually positive. And I know our staff were a little bit worried initially that this would be an avenue to complain and it'll be negative. Actually, opposite appears to be proving to be the case, which is great to see, and I hope our staff on that basis will see it as well. Okay, if there's nothing else, thank you, Natalie. Thank you, Janet, for those, and we'll move on to Workforce Committee. And if we're going in the same format, I guess Veena will start.
Thank you. So I'll take the paper as read, and just a couple of points to highlight, please. In terms of our workforce metrics, our turnover rates are still not where they should be, nor are our sickness absence levels, and again, appraisal rates haven't improved as much as we would have liked. There are a number of initiatives in place, as you know, to address these, but there is a recognition that those measures now require some fine-tuning, something which will now actively be happening. And part of that involves restructuring the way Workforce Committee works, and that work will now be underway as well. Interestingly, we do have some services, such as children, young people and families, where turnover rates and sickness rates are lower now. And we discussed at committee how that's come about, and Matthew explained how management information is being used in a much more focused way. So that there's some learning there really for us. Also on the plus side, the staff response rates for our May-June pulse survey has been the highest in quite a long time, which is really good to see. Our organisational culture score has improved significantly, from 59.9% in March to 64.1%. And we're also starting to see some positive words in the word cloud from staff feedback when they're filling in those surveys. When you look back at the word cloud, the words frustrating and challenging are always there in the centre in a very large font. And actually we're now starting to see the word feeling valued appear, and that's really heartening to see. We hope that's related to the Kind Life training that leaders have been attending. I want to stress though that that's a fantastic start to the work that's being done, but it is only a start. Nobody's sitting on their laurels, and we obviously need to see a sustained improvement in that area. A couple of important pieces of work that have been started, or continuing actually. Firstly, in relation to estates and facilities, we know from the staff survey and pulse surveys, and indeed the feedback we received through CQC, that our staff in estates and facilities have voiced a number of concerns. Practical concerns around inefficient timesheet recording, ordering processes, the need for more automated systems, but also staff feeling underappreciated, and there are significant recruitment challenges and cultural issues. We now have an action plan to address those concerns, which will include increased managerial visibility in line with the Visible Leadership Guide, which has now been launched. The plan also involves developing a sustainable workforce plan because we've got a number of retirements that are upcoming. We did discuss the point that we can't. That there's been a series of discussions, and whilst that's been really helpful, we can't just have a series of cosy chats with no follow through. And I think committee received assurance that the action plan is structured into work streams with dedicated owners, and they aim to address those concerns within very specific timescales, and those will be reviewed in 6 months' time for progress updates. Similarly, our admin and corporate staff, during a series of listening events, they have told us that they feel undervalued and underappreciated. It was interesting listening to the patient story first thing this morning, because they specifically talked about how important their admin staff are, because they were the ones who were chasing up, making sure the equipment was delivered and installed, etc., etc. But actually, large sections of our admin staff do not feel appreciated, and we have quite a high turnover rate, especially at Band 2 and Band 3. And both admin and corporate teams have said that they want a stronger voice and support at senior levels. So action plans, again, are being put together, which include standardising line management, embedding administration teams within clinical teams, reviewing and improvement recruitment processes, and for corporate teams, again, it's about providing that executive level support, building relationships with clinical teams, and promoting our corporate and admin services. Because ultimately, the heroes carrying out that patient-facing work wouldn't be able to do what they do without all those support services. So we're really keen to see all of that work come to fruition. Finally, the work around the resolution policy continues. We've already discussed the fact that it can't just be a paper policy. It's going to take time to make it work effectively and ensure that we really own and model that resolution culture, which means training mediators, coaches, investigators. That will involve investment, so we've got to do it properly. Board members will see that the assurance levels we've suggested in the report remain largely unchanged. We have a couple of new items, such as the work around the administration and corporate action plan, and also an issue around DBS checks. Assurance levels at 2 have been suggested because we're at the very start of that work. I'm sure Elaine and Natalie will provide further details of those, but I'm very happy to take questions in the meantime.
Does anybody have any questions on the committee report before I move to the workforce report? No, very comprehensive. Thank you, Veena, and hopefully green shoots. If we could note that report as suggested, including the insurance levels, and then move to the workforce report. Elaine?
If I start, thank you. If I start where you finished, Veena, just to provide board with an update on the DBS issue that was identified at the last workforce committee. Some significant work, we've made progress on that. We are currently in the process of sending out communications to staff, primarily falling into two groups. Group one being, we have no record for staff that they've had DBS check in the last 3 years, and they're probably on our old contracts. And also the second group being those where we need to check that we have something in place, but we currently have no permission on ESR to do that. Those communications are planned to go out next week. And the administrative support that runs alongside that, we have some resource for at least 6 months. They're due to start at the end of this month. We've also identified a priority group, it's a number of staff in particular functions. We're going to be looking at, and those are the groups where we're going to focus our attentions on and ensuring that we have some robust systems and processes behind that. So that was one of the things I wanted to update board on. Just to continue, so Veena's already talked about the workforce metrics. A couple of points around health and well-being of our staff, which we have discussed to some degree today. Around health specifically, we've had our Menforce conference. We're supporting staff around neurodiversity issues, and there is a support group in place which is well attended. We're continuing to encourage managers to have those one-to-one conversations with staff, picking up those health and wellbeing issues in a much more proactive way. On learning and development, in terms of training and ensuring our staff are compliant, research training is one of those areas where we have had to put some extra effort into. It is below. Funnily or not so funny, the training was impacted because of an infestation. So we've had to change venue. It is being addressed, but we're now putting on some additional sessions to deal with that. We have a new apprenticeship cohort starting in Q4 of this year as part of our new to care, but increasing our footprint in the apprenticeship space. We've talked already around Freedom to Speak Up champions. We have experienced some delay around the implementation of the app, which is being worked through. And I think because we're taking very much a mutual support approach, mutual aid approach with the acutes, we're being quite diplomatic about how much we lean into that, but it's going to take a little longer time than we had envisaged, but has not impacted on people being able to contact Natasha in any way. And turnover sickness we've talked about already. I think those are the main points I wanted to make. If anyone has any questions.
Sorry, my dog is going nuts in the background. Any questions? Natalie coming in first.
Thanks. If I could just pull out one additional point from the report, just would like to bring to people's attention the Guiding Safe Working Hours section on page 148 of Diligent, and it's really just to give a significant thanks to Dr. Emma Parry, who has been our Guardian Safe Working Hours. She's now handed over that tenure to Dr. Sarah Pepperal, who's a speciality and specialist doctor in perinatal care. So I just want to really thank Emma for her fantastic support in this area, and congratulations to Sarah, and I really look forward to working with her over the next couple of years.
Thank you, Natalie. Does anybody have any questions on any of what we've just heard across our workforce portfolio? No? Okay, then if we could note those reports then, please, and move to F&P. Beej.
Thank you, Mark. We were joined on this occasion by Rachel Hardy, who is an ICB NED and also the chair of the System Finance Committee who came to F&P on this occasion, mainly just to look in and see how things were going and to see the sorts of approaches we were taking to the discussions that we were having. And she took time out ahead of that just to meet with the other NEDs who also joined that committee. We were also joined by our esteemed chair of the Workforce Committee, Veena. Thank you very much for joining, Veena. In terms of the discussions on the assurance side of things, the key thing to pick out really is our financial performance so far. I think we've been somewhat prudent probably at this stage to give the assurance level that we have. Things are going to plan, and I'd assure board at this stage that that the team has got a handle on all the key things. However, it's early on, it's only month 2, so we'll see how sustainable our financial performance is. In terms of the information, in terms of the decision making, we saw talking therapies and inappropriate out of area placement recovery plans come back to this committee. They've been at F&P before, so I think the committee heard about the latest on those plans and also I think pressed for adherence and performance and delivery against those plans, albeit, as you said earlier, Mark, relatively speaking, inappropriate out of area placements for us are a good news story, but that's relative. In terms of information productivity, we all heard throughout the political shenanigans that we had at the election, productivity was a word that was used, probably overused by every side of the political reach, and it becomes more and more important for us to consider what productivity looks like for us. The centre has not given us any formula to establish exactly how we measure productivity. They are available for different types of trust. Acute trusts certainly have very clear approaches. So we've taken the earliest of steps to work out how we're going to approach productivity, how we're going to measure and represent what levels of productivity we are enjoying or not, as the case may be. So the team will be coming back to F&P at our next meeting with more concrete thinking on that. The EPR programme, which the board has obviously heard lots about, signed off on, that's going to plan at this early stage, and we'll be, as a committee, F&P will be keeping a very critical watch over the progress to ensure that sticks to timelines and to expectations. And then I guess finally, in terms of risks, none are identified for escalation to board at this stage. I welcome the BAF board development session that Jill mentioned at the beginning of this meeting.
Thank you, Beach. Yeah, no, that's great. Thank you. Sue has a question. Sue.
So when we made the Hillcrest decision, there was a conversation that that there might have to be an increased agency spend for the transitional period. Is that budgeted for, or is that likely to be an additional expenditure?
I suspect Matthew or Denise will pick that up. Is it Matthew? Denise?
Yeah, thanks, Chair. That will be additional expenditure, so that was not budgeted for at the time when we were doing our plans.
And therefore, I feel that demands a little bit more comment from somebody. So there was not money in the budget for the transition. So how are we making sure that we hit our financial targets whilst having that transition, which may involve additional spend on staff? Can anybody answer that at all?
Mark,
Matthew,
yeah. I mean, I guess the first thing to say is that we need to quantify the amount. The second thing I'd say is, in terms of our overall financial target, it's a relatively modest spend. You know, so it's some additional agency staff on one ward, so it's unlikely to impact our overall bottom line. The area where we need to assess the risk and offset other mitigation schemes is around our achievement of our agency target. Obviously, we're on a trajectory for that, and we'll need to build additional mitigations around other areas using less temporary staffing than we had previously planned.
Okay, thank you. If there's nothing else, we can note Beej's report. Thank you, Beej. I know the F&P's doing well on those items. Yeah, go on.
Can I just add very quickly? I like the approach that Janet and Natalie took on their respective reports, the colour coding and perhaps something for us to consider outside of this session is whether we can use and adopt that template across the other committees. Whether that would be useful to everybody, I imagine it may be.
I noticed that all the nods are all in all the right places there, Beej, I think is the way it could be put. So yeah, I think we can work towards that, definitely. Denise.
Thank you, Chair. So I'll pick up the performance report and just draw out some key highlights. So it is month 2, so it's the first report for 24-25. So the key things are there are a number of changes to the NHS oversight framework metrics. So I'll just pull those out, which is the inappropriate out-of-area placements. So that reporting has changed from a count of bed days to active patients. And active patients is a snapshot count at the end of every month. So at the end of May, we had 17 actually, and as Matthew's just alluded to, that has gone down where we are today. There was a recovery plan presented to F&P, and that was presented and approved. Just moving on to the adult mental health access target for 24-5, that target has decreased. It is a 12-month rolling target, and at the position in May showed we were performing above target. However, as that has gone down, we are still monitoring against the 23-24 target as well, just to maintain access levels. Picking up the children's and young people's mental health access target, again, that has reduced for 24-25. Just to note, this is an ICB target, and we are responsible for delivering 87% of the target. Again, it's a rolling target, and at the end of May, we were under target. Just worth pointing out, this does exclude some activity that does take place in schools. This is historically a manual data collection, so it's not in care notes. If we had included that figure, we would be about 95% of the target. So we're working with Gloucestershire Health and Care and Coventry and Warwick Partnership. They are both in the higher quartiles for delivering this target. So we're working with them to look at best practice and reporting processes. And just one more, talking therapies, again, the access target has been replaced in 24-25 with a number of patients receiving a course of treatment. And at May, we were under delivering against that target, and we saw a recovery plan approved and presented at F&P. Overall assurance level was a level 4 that we put forward. That was all I was going to highlight.
Yeah, thank you, Denise. Any questions for Denise on performance? I know all of these reports and these activities have been thoroughly looked at the committee stage, so we're mostly all aware of them. Anything? If not, I'm going to ask you, Denise, to move straight into the finance report before I then come back to the dementia diagnosis. Finance report is page 178 of diligence.
Okay, thank you, Chair. So again, this is the first report for 24-25. Just to remind a board, a revised system plan was submitted in June of a £80 million deficit for the system, and that was approved by the national team. Part of the system plan that we put forward was the trust had set a break-even plan for this financial year. That does include a 11.9 efficiency target. The Trust has a challenging plan to deliver for the year ahead, but we do have robust arrangements in place. Key element is the delivery of efficiencies. As Beej alluded to, performance at month 2, we are on target. We have delivered the break-even plan. Efficiency delivery was slightly ahead. I'm talking slightly ahead, and agency spend is currently below plan. And that's due to the phasing of the plan. So the plan for agency does reduce in going throughout the year. Looking at the run rates for the first 2 months of the year, they are consistent. However, as Bee's alluded to, it is month 2, it is early days. It's going to be a tight financial year, and it is again around the sustainability of the finances. That's all I wanted to pick up, Chair.
Thanks, Denise. Anything with regard to our finances? Bearing in mind, of course, as Denise says, it is early days and we're 2 months in, but good to see that we're on track with things. Okay, if we can note that report, please. And if we move to dementia diagnosis, to remind colleagues that we had the deep dive at our development session last month. So this paper merely sort of formalises what we all had quite a lengthy discussion about when we sat together at Hereford last month. But nevertheless, I wanted it to come forward for public viewing, so public and partners can see the activities which are significant that are taking place for us in terms of our trust and how we contribute to this system target. John.
Thank you, Chair. Improving the identification of dementia, the diagnosis of dementia, and providing the post-diagnostic support for people with dementia has been a national strategy for several years. And our ICB and our CCG prior to that have been leading the system response to the implementation over the past several years. We have come under significant regional pressure recently from NHS England because our performance targets fall very much below what is expected in terms of the prevalence of dementia in both our counties. As part of the mental health joint collaborative arrangements between the ICB and our trust has been asked to lead the system response to recovery of the dementia diagnosis rate. So we have been leading this, and I've taken on the SRO responsibilities for this program, supported by Anna Evans, our clinical lead for quality improvement, and working very closely with the program team within the ICB and with other partners from primary care, acute trust, and from the voluntary sector as well. As you would have picked up, the dementia diagnosis rate is the measure that is used to indicate how well we are performing, and the target for us to achieve is that 63% of our predicted prevalence we have a recorded diagnosis by March 2025 and 67% by March 2026. So obviously other pieces of work which have been happening for the past several years will continue. We are currently looking at the data quality side of things, and after rectification of that as soon as possible, we're also in parallel looking at how we improve the identification and referral process, but also the post-diagnostic support that will be required for those who have been diagnosed. So our trust has just started leading on this at the moment, and I will be keeping the board updated on progress in terms of our targets going forward. Thank you, Chair.
Thank you, John. Does anybody have any questions at all? I know we had a thorough go at this. Okay, can I make a request, John? Can you get together with Sue, if that's okay, Robert, just to discuss how we keep board topped up with this, because it is an ICB target, yet it sits within a sort of a priority for us to try and assist as much as we can. I'd like to think board keeps topped up, but I don't know what the mechanism is, but somewhere between you and Sue, I'm sure, can come up with a method of keeping us topped up on progress. Okay, thank you. If we can note that report, and thank you for all the work that you and the team are doing behind the scenes on this, John. I know it's not an easy one. It's been a thorny subject for a number of years, I suppose. So I think everybody, including the ICB, are pleased that we're rounding it up and trying to get on with improvement.
Just on the reporting to our board, Mark, the Dementia Task Force is reporting to the Mental Health Joint Committee, which provides a report here. So that would be the way I would think board will be updated.
Provided it comes to board in some way, John, yeah. I don't mind the mechanism. Thank you very much. Yes. Okay, so if that's noted, we can move on to Audit Committee, Martin.
Thank you, Chair. So the audit committee held on the 26th of June was focused solely on the closure of the accounts for the last financial year 2023-24 to receive the external audit report, internal audit assurance level, and for us to approve the financial statements, the annual government statements, and the management representation letter, which was signed. All of those very successfully approved by the committee. The external audit report, as ever, includes a number of recommendations. First and foremost, I think, is that they issued a modified audit report. The audit report that they do is predominantly in two principal sections. One is in relation to the financial statements prepared by our team, which I'm glad to say they concluded the opinion that they did show a true and fair opinion, true and fair view of the financial statements and the state of the financial health of the organisation. So we're very grateful for that. And I know we take it as a matter for granted in this trust, but actually it goes down to a huge amount of work done by our financial accounts team and everyone else in terms of complying with the processes. Thank you for that. Where they did offer a modified audit opinion was in relation to raising a matter of exception in relation to our value for money audit and the best use of resources. And that specifically relates to the change in our CQC rating for well-led around to requires improvement. And whilst they didn't pick on anything in particular of note, they recognised our improvement plan covered that, but it hadn't been far enough advanced in order for them to take a view on that to in any way and so override the CQC report. My expectation is they won't review that until the CQC have reviewed that, and they did confirm that that was consistent with other trusts that we do. The other element is in terms of internal audit, they're required to give a view on our internal controls and the work they have undertaken over the year in relation to our financial accounts and financial systems and processes, and they gave a significant assurance view, which actually is changed. They've changed the mechanism by which they do that, and it's down to a higher standard than perhaps previously reported. So we're very grateful. I'm very glad that we did achieve that higher level of getting significant assurance. Those are the only matters I was going to bring to the attention of the board, and if anyone's got any questions.
Thanks, Martin. It doesn't look like there are any questions. No, thank you, and thank you for the work of the finance team. I can echo that. Thank you. If we can note that report then and move on to the Mental Health Collaboration Joint Committee, Carol.
Yes, thank you very much, Mark. Yes, this is we've actually managed to fit in 2 meetings since the last board meeting. The meeting we were going to have in August, actually, we brought forward to July. So the report the paper that you've had relates to the first of the 2 meetings in June. And what I was planning to do is just give you a very brief update on the things we talked about at the second meeting, if that's OK. But you'll hear more of those, get more detail on that when we have our next board meeting. So most of the paper, I think, is pretty self-explanatory. It's quite encouraging to actually be able to make some actual commissioning decisions, which I think is part of the purpose for that committee being set up. So that in terms of that children and young people's procurement, I think that was really helpful. The LD and autism deep dive actually turned into more of an overview because we brought the meeting forward, but with a commitment to bring that back as a deep dive later in the year, linked to a review of the collaborative. So one of the things we agreed at the meeting in July is that there would be a review of the Mental Health Joint Committee and the arrangements. That would look at performance, outcomes and governance, and that will report by the end of October. And this is very much being recognising the changed context in which we're in now, with the Trust's improvement plan, with the other stuff that are happening nationally, and we really just need to make sure that the Mental Health Joint Committee is doing what it should do. And I think I'm particularly pleased that we're going to include the outcomes in the review, because otherwise how can we ever work out how the committee's making any difference? So I think that's it. And well, just the last thing, I think I'm not going to go into any detail at all about the dementia recovery rates. We seem to talk about those at every meeting, but we are keeping on with that through that Mental Health Joint Committee. Thank you.
Thanks, Carol. Anybody got any points of clarification, questions? No, thank you. Thank you, Carol, for that. That concludes our committee reports and activities. Can I thank all the committee chairs and non-execs and the executives that support the committees? I think I'm feeling a degree of movement in all the committees on the issues and a recognition of the difficult work that all the committees are doing. But I sense that a grip is being had on these things, and it plays into the improvement plan and it plays into our culture. So thank you for everybody that's working hard on that. We now move to annual report on infection prevention and control. Natalie, this is before you say it, this is a necessarily long report because many things in there are stipulated by our lords and masters at NHS England, which is why it's probably lengthy in tone. But Natalie.
Thanks, Mark. Absolutely. It's lengthy. I appreciate that. It's also very technical. So just full assurance to board. This goes through the Infection Prevention Control Committee, which is where our IPC and microbiology experts sit. So it is scrutinised by the experts before it goes through Q&S up to board. I just want to really thank the IPC team, but also the housekeeping and the clinical teams that deliver the IPC practice in reality. The work schedule this year has been significant, but we have continued to really successfully manage infections across the organisation. And I think we have a really successful story here to talk about. And I said I want to thank all of those teams involved. I won't talk through the report. I do appreciate it's very detailed. It goes through the work schedule, management of infections, and all the education and audit work the team do. So happy to take any questions.
So.
Well, I also wanted to echo what you just said about congratulating the team, especially on containing the Malvern norovirus outbreak. That sounded very successful. Could we, the RSV vaccines, are we going to be responsible for delivering them, or is it too early to know?
It's too early to know. I doubt we'll be responsible, but it is too early at this point to know.
And do we know if staff will be expected to have them? Is it going to be like the COVID?
At this point, we haven't been given any information. The only vaccine programme we're currently working through is the whooping cough vaccination programme. So it's, no details yet as the RSV.
Okay, thank you.
Thank you, Natalie. If there's no other questions, Natalie, can you, I know you would do it personally, but can we, on behalf of the board, thank the team behind this? Having these infection prevention control measures and oversight in place is absolutely crucial to the effective and safe running of our trust, and very much of this goes on behind the scenes with our technical experts and Carol and the microbiologists. So please pass on board's thanks. I think it's very well founded. Thank you very much indeed, and we can note that report, which then takes us through to the annual comms and engagement report.
Thank you, and it's always a pleasure to be able to update board with the work that goes on in these two teams. They are small, but the depth and breadth of what they deliver for the organisation is not to be understated. So I want to start by thanking them. We've had an interesting year from a comms point of view. I mean, Fee started with us a year ago. Obviously, we've had a really important improvement journey, and putting the comms around that has been really critical. So I'd like to just extract that first and foremost. Likewise, the board's obviously prioritising, making sure we've got the patient and carer voice as strong in our decision making, and really embedding that patient experience into quality improvement. So a lot of work happening across the patient, public engagement, experience and participation team. They do appreciate that's a long title. The care opinion, we've received an update on at senior leaders, and that's obviously triangulated with a lot of other work we're doing around getting that feedback into our structures and processes, integrated governance in particular. As a board, we've received updates on our volunteers. Again, would like to say thank you. We've got new volunteers now with iPads going around our community hospitals, collecting patient and carer feedback. It's a really dynamic space. We're seeing a lot more interest over a number of roles across the trust, from general volunteering to helping us strategically plan and improve. From a kind of marketing communications point of view, the turning the handle on the internal comms, we did a review. I think we're in a much better place now in terms of making sure we don't overwhelm staff with too much communication, but they really do get an opportunity to get the headlines from across the organisation. And the Let's Talk has been incredibly popular. We're up to potentially 300 to 400 for some topics, which is just great. And we want to try and build and do that and do more with that. Obviously, they've done dedicated work on recruitment and retention. We've got some big transformation works which they've been wrapped around, and that's alongside the usual work that we do around trying to push out the achievements and the positive work that's happening across the organisation. Not least as well, we've had a very successful staff awards. That comes around quickly, and the team do that underneath the surface, really. It's a big piece of work. The AGM, the annual report, for other sort of key parts of the marketing communications portfolio. So finally, I wanted to say that Natalie referenced earlier the health inequalities work. So Jane Thomas has been instrumental in my team, helping me pull that programme of work together. It's early days, but it gives us a board home for really making sure we are embedding health inequalities across the organisation. We remain in a position of potentially just trying to get what we need around data and that kind of reframe of what we want to do differently. But now I can see how we can wire it through into our programmes of work, into our governance. And I think the recommendation is that becomes a formal subcommittee of quality and safety. But so that's a really, really exciting piece of work for us as a board. We've talked about it a lot, and that really puts some grip and traction into that space. So yes, finally, again, to say thanks to the team, and it's been another really busy year, but they've just done it and they continue to do it. So yeah, that's great.
Thank you, Sue. Any questions on our comms team? From my perspective, I see there's not many aspects of our improvement plan that don't require some form of communications, notably internally, to assist the delivery. So it is behind the scenes, but it's critically important to our improvement journey. So thank you to the team. Right, thank you, Sue. If that report can be noted, that then takes us to the items on the agenda where the reports have been considered elsewhere, but they're put on the agenda for information. So that's the annual complaints, PALS and legal report, which went to Q&S, EPIR, which gone to Quality and Safety, Quality Count, which was signed off by the Quality Safety Committee, and of course the Joint Forward Plan and appendices, which will be signed off at ICB and other forums across our footprint. There were no documents for signature or sealing that have been brought to my attention. There have been unfortunately, no appointments through the Advisory Appointments Committee, which is always a disappointment, as we know that the more consultants we can recruit, then the less our agency spend will be. But I look forward to seeing some more appointments within that box. BAF. Is there anything that we've discussed today, so it's item number 28, that we think needs to be included within the BAF or considered for the BAF? No, there's one that I would like us to consider for the session this afternoon when we come together is all about widening our understanding and development around children's services. And I think at the end of that session, probably we need to ensure that we are content that the risks around children's services are accurately reflected within our BAF and how they may or may not affect our strategic aims. But that's not for now. That's just for once we've had that input, I would suggest. Apart from that, if there's nothing there, I've had any other business has been notified to me. The date of the next meeting is 19th of September. And if there's nothing else there, I bring this meeting to a close and remind colleagues that we meet again at 10 to 2 this afternoon for our development session, which is focusing very much on the children's services. Thank you for your participation today. Thank you for colleagues for the changes to papers, the refocusing of papers, the continual drive